Okay, good afternoon, folks. Welcome. We are coming to you live from the Cardiovascular Prevention and Rehabilitation Program at the Rumsey Center of Toronto Rehab University Health Network. It's our pleasure to be with you in the room, in the facility, but also broadcasting live across the University Health Network family. My name is Paul O. I'm the medical director in the program. And it is our privilege and pleasure to welcome you to the Mark Rochon Distinguished Lecture Series. Before I introduce our speaker, let me just say a word about the program. These are a series of outstanding lectures with renowned investigators, researchers, clinicians from around the world. For those of you who may not remember Dr. Rochon, Mark Rochon. Mark was our CEO of Toronto Rehabilitation Institute about 20 years ago to about 12 years ago or so. He was the CEO when I was appointed as medical director in this facility. He was an outstanding leader, a wonderful colleague, provided visionary leadership in the government, in policy, in shaping the healthcare system in Toronto. So we are indebted to him for his leadership and vision in bringing Toronto Rehab into the family at the University Health Network. And it's great that there is this enduring legacy through the Mark Rochon Lecture Series. Susan Marzolini is our current chair for this series, and we're very grateful to you, Susan, for orchestrating these amazing events and finding fantastic individuals to share their expertise and wisdom with us. On that note, it is my distinct pleasure to welcome today's speaker, Dr. Martha Gulati. Dr. Gulati has been a fantastic colleague, mentor, sometimes debating friend. Yes, Martha? Martha and I shared a virtual podium a few years ago. Dr. Martha Gulati is a professor of cardiology at the Houston Methodist Hospital's Health System, and she holds the Davis Chair in Women's Cardiovascular Health. She has had many leadership roles, including being the immediate past president of the American Society for Preventive Cardiology, and is the inaugural Davis Chair and Director of the Davis Women's Heart Center. I'm sure we'll hear more about your fantastic work at the Houston Methodist. She is a leading expert in women's heart health. She is the author of Saving Women's Hearts and has chaired national chest pain guidelines. She has received numerous awards and accolades for her groundbreaking research and advocacy. And she's got a great social media presence as well. So you'll find her kind of featured throughout not only medical media, but general media as well, advocating for women's heart health. Martha, thank you. Welcome to the podium.
Well, thank you. Thank you for this kind invitation. It's always so good to come home. I was just telling people that when I landed yesterday, I don't know, it was a little emotional for me, just because I haven't been home in 2 years. And so I just always, when I come back to Canada and back to Toronto, I always feel like I've come home, even if it's not where I live anymore. So I'm going to be talking about, is there really a sex difference? And to really highlight some of the things related to disease, but also related to prevention. My disclosures are here. There's nothing really that my disclosures that are related to my talk per se, aside from me being part of the Warrior trial, but I don't even think I have a slide necessarily about the Warrior trial today. So, women's cardiovascular health has really been neglected by cardiology in the medical community. Women are underdiagnosed, women are undertreated, women are underrepresented, women are understudied. And the cost has been the lives of women. Once women have cardiovascular disease, we know that they're more likely to die compared with men, particularly younger women, women under the age of 55 who have heart disease. That is the group that we've made the least amount of impact in, and heart disease does occur in younger women. And I love for those of you that might read philosophy in your spare time, you might have read The Other Sex, and that was by Simone de Beauvoir. And she wrote that, about the other sex just in general in our greater world. But I do think it's the way that we have treated women. And I was hearing even at rehab in the early days of this rehab, which is to me the highest, the best rehab that I've ever seen in my life. When we talk about it, I even heard here that women weren't allowed necessarily to come or to do certain exercise. It took a long time for us to really be inclusive. Cardiovascular disease, though, is the leading killer of women. In the US, of the 1.85 million deaths, over 446,000 of them are due to cardiovascular disease, making it the leading killer of women. The next leading causes are chronic lung disease, lung cancer, and breast cancer is the fourth leading cause of death. There's almost a 10-fold greater risk of dying from heart disease. But when we talk to women about what do they get concerned about, it's always breast cancer, right? Like they're not worried about their heart. They haven't done preventative therapies for their heart the way that they have done their mammogram on a routine basis. And then even in terms of prevalence, sorry, I don't know why it's not advancing. We've practiced this and it worked fine. I'm so sorry. Just see. Okay, there we go. Yes, sorry, in terms of prevalence, 62.5 million women living with some form of cardiovascular disease in the US and 4 million living with breast cancer. So just, again, I only present that because women, our patients, don't always recognize this. They're being told a lot when they go for care that, to get their breasts screened, et cetera. They're not always getting told about their heart, and this remains a problem everywhere. In Canada, of the 160,000 deaths of Canadian women, over 39,000 of them are due to to all cancers grouped together, and about 36,000 of them are due to cardiovascular disease. So these are the statistics that I could extract. Again, chronic lung disease and then Alzheimer's these are the numbers for Canada, but the leading cause ultimately is cardiovascular disease because separate cancers don't, individually will never meet the number of deaths due to cardiovascular disease. And in Canada, it's also true. The deaths 7 times greater to die from cardiovascular disease than breast cancer, and women who have had an acute myocardial infarction in Canada are also more likely to die than men. So given that when women are more likely to die, and we have many different examples of studies, this is just one. This is the Isaacs Archive study that had about a third of women. This is an international study looking at mortality when patients have acute coronary syndrome. And I'm going to use a lot of examples of acute coronary syndrome because a lot of countries have registries for that. But what they found, as many studies have previously found, that when women have an acute coronary syndrome, they're more likely to die, and they're more likely to also have acute heart failure, hospitalization, particularly the ST elevation myocardial infarction group. And that has been repeatedly shown. This is just one study, but I could pull up many studies. And so right now, when we go through the differences about why women don't do so well, I want you to think, is it gender or is it sex? Not to be political at all. Gender, of course, is a social construct. How you're seen in society affects your health care, right? It affects your lifestyle. It affects your access to care. It affects your income. It affects where you might live. But biological differences, if you're an XX woman versus XY man, every cell in our body has a sex. Therefore, every gene and every molecule is influenced by our sex. So how a disease will present is going to be different. Additionally, of course, hormonal status will differ. And pregnancy history, obviously only unique to biological women. So all of this matters to health and health outcomes. But as we're going through this, ask yourself, is it gender or is it sex? Because I think both play a role. So there is a lot of gaps in cardiovascular care that we continue to identify. And particularly after having myocardial infarction, we know that women get undertreated. From the FAST MI group, they looked at just younger women. Again, the idea was, why are younger women more likely to die? And so they looked at just those under 50 who had a heart attack, and they looked at both men and women. And what they found was that women were undertreated. Women were less likely to receive guideline-directed care, and women were less likely to be taken to the cath lab. Interestingly, in the French data, they did not actually find a difference in mortality. And so to me, it's like, well, if you treated women better, maybe they would have less mortality. But that's the only study that I can find that has shown less like the equal mortality. Because we looked at it using the young MI group, and this is using the data from the Brigham and Mass General, and we were able to demonstrate, again, in those under the age of 50, under treatment, less likely to be taken to the cath lab, less likely to get guideline-directed medical care after myocardial infarction, but women were more likely to die compared with men. So, and there's so many different data, like we'd be here all day if I took you through all the data, but part of it might have to do with how we even approach women when they present, right? When they present with chest pain, there might be differences, but say that they do say chest pain or chest pressure, do we treat them differently? Well, from the National Hospital Ambulatory Medical Care Survey from 2014 to 2018, they looked at all ER visits for chest pain or chest discomfort. So this isn't saying the people that might present differently. These are people that actually reported the symptoms that we, at least most people would say, are at least consistent with a myocardial infarction. And they looked at just the young people, young adults, so under the age of 55, and this represented 29 million emergency visits. And what they found is women were less likely to be triaged as an emergent case. Women waited about 10 minutes longer to be evaluated. They were less likely to receive an EKG or be put on cardiac monitoring. They were less likely to be seen by a consulting cardiologist or any consultant for that fact. And they were less likely to be admitted to the hospital or to the observation units. So they also saw the same findings with people of color. So this tells you it's more about how we see women when they present with chest pain, because we are not treating them the same, certainly, as men. So that's people who present, with this. And we have many examples of where we undertreat women even after they have a heart attack, that we aren't treating them the same. And this is a study that just looked at patients with atherosclerotic cardiovascular disease and just asked a very simple question. Did you get treated with a statin or not? And did you get treated with a high-intensity statin? Because at that time when the study was done, that was the main medication that we had that was within our guidelines. And we don't do a great job with statin therapy in men or women, because as you can see, over half the patients didn't get a statin therapy, and yet they have atherosclerotic cardiovascular disease, and about a quarter of them got high-intensity statin. But the odds of getting a high-intensity statin was greater if you were a man than if you were a woman. So that's been replicated in many studies. We know from the PALM registry too, which is both primary and secondary prevention, that women are less likely to be on a statin even if they meet the criteria for it compared with men. They often are not offered a statin, but also women have the problem of declining a statin and discontinuing statins too. So those are issues that we certainly have to deal with, but I think where the barrier is, if we're not even giving it to them, that's a big problem. And this is a study that looked at an international database. This was published in the International Journal of Inequity in Health. And they showed that, again, these were people with acute MI, acute coronary syndrome, and stroke. And they showed that women were less likely, again, in all these countries that they gathered data, to receive guideline-directed medical therapy. Women themselves were less likely to be adherent. Women were told more frequently to make dietary changes, and discussions about their weight occurred. Men were more likely to be told to increase their physical activity, and therefore they were more likely to increase their physical activity. Women had lower rates of risk factor testing and less likely to achieve their cholesterol goals. And again, I know all of you deal a lot with cardiac rehab. The female sex was associated with lower rates of referral for cardiac rehab, which has been repeatedly demonstrated, and I know much of that data even comes from here. What we also know is that once a woman has a myocardial infarction, she's more likely to be rehospitalized. And this data comes from the TRIUMPH study that looked at rehospitalization after myocardial infarction, both by sex and age. So women are shown in gray and men are shown in black, and the younger people are the solid lines, and the broken lines are those over the age of 55. Well, they showed, you can see within that first month of being discharged after acute myocardial infarction, these lines start separating. And particularly for the younger people, you can see the solid lines are the ones that are separating the most. And that continues out to past 12 months where they followed them. And certainly for older women, there was also a greater rehospitalization, but not as much as the younger women. So this may be because of the under treatment of women. Certainly that can be part of it. The under referral to cardiac rehab is also another issue that we know if you go to cardiac rehab, you're less likely to be readmitted. So these are things that we are still trying to figure out why they continue to occur. And even when a woman has a myocardial infarction and they're the sickest, so when somebody presents with an ST elevation myocardial infarction, in cardiogenic shock, we know many of those patients, right, are going to die. We need to pull out everything, do everything that we can to try to save lives. And yet what we find is that women, we don't send them for revascularization when they present in cardiogenic shock at the same rates as we do men. We don't offer them mechanical circulatory support. We're less likely to do a right heart cath on them. And ultimately, this is from the national inpatient sample from the US, and they showed higher mortality rates in women. And there were also racial differences. If you were Black or Hispanic, they actually had higher rates as well. So these are things that are not due to biology necessarily, but the response we have as a medical community to treating them. So just in summary, because I've talked a lot about acute coronary syndrome, just to put it all together, women are less likely to receive the guideline-directed medical therapy. When we talk about first-person contact to balloon time or door to balloon time, if you will, we know it's longer for women compared to men, and women aren't even taken to the cath lab as frequently as men. We know if you use fibrolytics, as some areas have to do, same thing, first-person contact to fibrolytic time, longer for women. I already showed you examples where we don't use guideline-directed medical therapy as aggressively in women, and it doesn't matter if you look at within the first 24 hours or upon discharge, same point. Women are more likely, as I showed you, to be readmitted, and these readmission rates have not gotten better with time. And mortality, of course, is higher, particularly with ST elevation myocardial infarction, and as I discussed, in younger women. And I will also point out it's a global problem. I used to say that we didn't know much about Africa because that continent we had no data, but we just published that data and actually show again that there's no place free of the bias in our care, unfortunately. It has been replicated in so many different countries showing that we are not treating women as aggressively. And that's just one part of cardiovascular disease, right? Like we also deal with patients with heart failure. We can look at that data too and demonstrate, and this comes from a Optum database, which is a very large database that looked at heart failure with reduced ejection fraction. And they just looked at utilization of any guideline-directed medical therapy at any dose, which is like a low standard, right? But even there, you can see that there was a bias. Women are in red, men are in blue. But if you have that very liberal definition of treating people, 80% or so got on treatment and about 85% of men out at 12 months. Okay, but then when you actually say utilization of optimal guideline-directed therapy, and that was, even that I find a liberal definition, but 50% of the target dose of beta blocker, 50% of the target ACE or ARB, and any dose of an ARNI, and any dose of an MRA. So that was a very generous definition. You can see that we're very bad at. Only 2.4% of women at 3 months were on guideline-directed medical therapy, and only 3.3% of men. So it's not great for either. And out to 12 months, it doesn't improve that much, unfortunately, for either men or women. But there's always this gender-based gap in our treatment. And we could go through so many different cardiac conditions, and I can show you where we have bias introduced into care. Like TAVR, for example. TAVR, we've been doing it now for a number of years. The early TAVR studies actually showed that women did better than men with TAVR, and yet when we utilize TAVR or implement it in people who need it, there's greater delays in women actually getting TAVR when they meet criteria for it compared with men. And there's other, surgery, we've had continuous gaps in outcomes related to surgery, a lot more bleeding, a lot more stroke in women. The only good news I would say after TAVR is that women are less likely to require a pacemaker than men. So it's probably less costly for us to do TAVR in women. Think about atrial fibrillation. We all deal with so many patients with atrial fibrillation, but I'm sure many of you have noted that women are less likely to receive adequate anticoagulation. They're less likely to be offered rhythm control or ablation procedures, yet women are more symptomatic when they're in atrial fibrillation, when we leave them in atrial fibrillation. And ICD use, particularly CRT use, which the early Made It trial showed that women actually did better if they got resynchronization therapy, if they met the criteria for it. Even though they didn't enroll that many women, it still came out as very strong sex difference. And yet in real life utilization, we are less likely to implant CRT into women compared to men. And heart transplant too, women are only a quarter of the LVADs in the United States, and therefore they're only a quarter of the transplants that occur. And interestingly, when we look at the data related to transplants, women receive poorer quality hearts than men, and yet they do as well as the men do. But we still somehow think it's okay to implant a less high quality heart into a woman than a man. So, I know we don't have enough organs to transplant, but nonetheless, this annoys me to no extent. Now, some of you might be saying, well, some of the delays in care might be because women present differently. Well, do they? When we see a man who might have dropped something on his toe and we suddenly do an EKG because he mentions chest pain, okay, good, I'm glad the man got the EKG, but when women come in complaining of chest pain, why do we jump to the diagnosis of anxiety? Why is that the first response in our medical community? Why do we use the word atypical chest pain to almost always describe a woman's chest pain? And, we looked at this because when we were writing the chest pain guidelines, that was the guidelines I got the honor of leading, I wanted to know what did the data really say? Well, for younger people, we didn't know much until the Virgo study. The Virgo study is a study of patients under the age of 55 who have had a heart attack. And so these are young men and young women, and they actually were able to record their symptoms. So they actually had documentation of their symptoms. And what they found actually in Virgo, for young people who have a heart attack, 90% of women and 90% of men reported chest pain or chest discomfort. The difference for women versus men, though, was women were more likely to describe 3 or more accompanying symptoms. And chest pain might not be the most predominant symptom, but they definitely reported that they were having chest pain or chest discomfort. Interestingly, in Virgo, they did ask a really good question. Did you seek out care before this heart attack? And actually, women were much more likely to have sought out care than men, but they were more likely to be told that this was not cardiac, whereas men were much more likely to be told it was. The high stakes group, they're the ones who brought us the high sensitivity cardiac troponins that I think many of us are using these days. So this is all ages. This isn't young or old, it's just everybody. And they created this bullseye diagram, and some of you may have read this paper a few years ago. And they showed women in red, men in blue. Actually, there was more women with the quote-unquote typical symptoms that we would recognize than men. And they also showed about 90% of women said the words chest pain or chest discomfort. But again, women were more likely to have additional accompanying symptoms. Then there was another interesting study done that was called the Hermes trial. And the Hermes trial, it's not about the scarf, even though it has the same name, and it wasn't about the Birkin either, but they listened into the conversations. So that basically it's cardiolinguistic technology, AI, the simplest form, a computer recording what people say without bias. And there too, they demonstrated that the women that went on to have a myocardial infarction actually did report chest pain when they were communicating with the doctor. Again, women were more likely to have additional symptoms, and sometimes the symptoms were different, but it wasn't that they didn't use the word chest pain or chest discomfort. The question really is, did we hear it? Do we listen for it? Are we listening to our women when they're reporting what is going on? So when we wrote the chest pain guidelines, this was one of our class 1 recommendations, is that you should no longer describe chest pain as atypical because it's not helpful. Usually when people say atypical, they don't mean presenting differently. What they mean is it's non-cardiac. So that's at least when my fellows, they don't run to me to tell me about atypical chest pain. They run when they think it's a heart attack, right? So, and chest pain should be described as cardiac when you think it's cardiac, non-cardiac if you don't think it's cardiac, and possibly cardiac when we don't know. That's why we do additional testing. That's why we're there. That's why cardiologists exist, is to evaluate chest pain. But as cardiologists, we can't do anything if we're not called, right? So that's always the challenge. So this is in our guidelines. I still have to beat out of my fellows to not use the word atypical, but I do hope we can start. Words really do matter, and they matter how we appreciate our patients' voices. Well, there are some sex differences, though, in cardiovascular disease, because I've talked a lot about the bias and the sort of related to gender. But of course, we have understudied women, and so we're only now understanding some of the biological differences in cardiovascular disease. And I can give you lots of different examples, but I'll give you what I kind of focus on in my clinical practice is the idea of women not having obstructive coronary disease. And we know we now have terms for these. When I started out, it was called Syndrome X, and then Syndrome X is always the name in cardiology we give to anything we don't understand, but that's what initially they did call it, and now it's called ANOCA, MINOCA, SCAD, and I think ANOCA and MINOCA are just buckets as well. One day we will use proper words for the different types of diseases that fall in there, but this idea that even the smaller vessels that we don't see in a cath, that there's something else going in the microvasculature. These are things that we need to look at. SCAD, of course, is different, and that is something that, again, we don't have a lot of understanding of, but because we don't have good trials, but at least we have some registries. Takotsubo's cardiomyopathy, stress cardiomyopathy, broken heart syndrome, all the same words for the same disease state. But this idea, again, out of 10 patients, 9 of them will be women. It is a female predominant disease. And this idea that the brain and the heart are linked more closely in women compared to men has some weight to it. So this is something that, again, we don't have great treatment because we still need to do a better job of studying this. But again, we have some registries. Heart failure with preserved ejection fraction occurs, of course, more frequently in women compared to men, sort of a 2-to-1 ratio, whereas the flip is true for HFrEF. And of course, peripartum cardiomyopathy is much more common. It's only possible in biological women. So it's a very sex-specific, sex-unique type of heart failure. But there's many different conditions that we are now trying to appreciate more and study more because I think we're now getting studies done in women and being inclusive. The idea about non-obstructive coronary disease, though, it isn't something new. We did see it. Like, you can look way back in the older Gusto trial, to get in these studies, you had to meet the criteria for STEMI, non-STEMI, and unstable angina. And they did show that people were having these events without obstruction. They didn't know what to do about them, but they did report them. And it was much more common in women. We had studies that followed that, like the Women Ischemic Syndrome evaluation, and now the Warrior trial and the Cormica trial. So we do have some studies that are helping us figure out more about this disease. Even in the ischemia trial, though, in a contemporary era trial, to get into ischemia, you had to have moderate to severe ischemia on stress testing. And even there, with that much ischemia, 14% of them had no obstruction in their coronary arteries. So, we keep documenting this. we were one of the first, actually, I think we were the first to report this, that it wasn't benign, because before that everyone said it was. This is our study that was published in the Archives of Internal Medicine, and we compared the WISE population to the Women Take Heart population. The WISE is the Women Ischemic Syndrome Evaluation population, signs and symptoms of ischemia, but no obstructive coronary artery disease. We compared them to the Women Take Heart, which was an asymptomatic cohort of women that we age and race matched them. And you can see that we showed that for the WISE women who had signs and symptoms of ischemia, they still were more likely, compared to a normal cohort, to go on and have cardiovascular events, including heart failure, which was the first sign, perhaps, that HFpEF might be aligned with ANOCA. But we did show a rate of 2.5% per year, so it's not a benign condition, and other people have since replicated that and shown that. And the only point I'm trying to make is that when you study these things, you find out, because when I was a medical student here at University of Toronto, I was told that the only way that you could have angina was to have an obstruction in the lesion, and if not, we would call it a false positive. We wouldn't know why the troponin was elevated, but we just moved on to the next patient, but we didn't offer anybody any of that treatment. But there's a lot, that's just the tip of the iceberg, right? Like everything below that is important, and you can be symptomatic with it. And so I think this is the thing that we are learning much more about. In our chest pain guidelines that we put out in 2021, we actually insisted that we include a pathway for ANOCA, because we had not really had any guidelines addressing that. And so it was in our guidelines, we gave it a class 2A recommendation to either use coronary function testing or cardiac imaging to try to determine what's going on and make a better diagnosis. Particularly at that time, we had the CORE-MICA trial, which was a randomized control trial showing that when you did coronary function testing in the cath lab, you were able to improve their quality of life and reduce their angina. Now, the European guidelines gave it a class 1 recommendation. They don't have an additional randomized controlled trial, but I guess they thought 1 was enough. They gave it a 1B recommendation to use coronary function testing. I'm just glad it's in both guidelines and that people are now doing it more. Still not enough, but more than they were in the past, at least in the US. And I'd be interested to hear what you guys, if you're doing this here or not, because I think this is always the challenge. I'm part of the Lancet Commission that is looking at disparities in cardiovascular health, and this comes from that. One of the groups is women. It's not the only groups, but this is from our paper related to women, talking about not really understanding ischemic heart disease in women in so many different ways because we haven't studied them. And so there's still a lot of work for us all to do, because these disease states that are unique to women, we don't necessarily know how to adequately treat them. That's always the question. We did have the Warrior trial, which was the study we had hoped would answer it, and it was a negative trial, unfortunately, and we can talk about that more. But I think that we still need trials to really know how best to treat these women. But I am a preventive cardiologist, so I would rather just try to prevent cardiovascular disease. So, one of the things is when we address cardiovascular risk factors, even understanding what's different about risk is important. And when we think about the traditional risk factors for cardiovascular disease, which we'll ask about in men and women, we should understand and appreciate their differences. Things like diabetes, right? Like we know if you have diabetes as a woman, you're much more likely to get cardiovascular disease than a man. And that may be because of vascular effects that are different based on diabetes. It also may be due to undertreatment of diabetes for women. We know things like Lp(a) differ in women's lifespan versus men. Men, it's constant throughout their life pretty much, but for women, there are times of change, and interesting, Lp(a) will increase by about 20 to 30% at menopause and stay elevated. So it's maybe somebody who's been identified as intermediate risk might be pushed to high risk. We certainly know inflammation Apologies. Hello? Okay, great. Sorry. So even when we talk about inflammation, C-reactive protein, of course, we see higher levels in women compared to men, but also autoimmune diseases like lupus and rheumatoid arthritis are much more prevalent in women and are strongly associated with cardiovascular disease. And even migraines, I think we should be asking more about migraines. And I think last night they lit up the CN Tower purple for migraine awareness. But I do think that women are more likely to have migraines compared with men. And we do have data associating it with a greater risk of endothelial dysfunction and platelet aggregation, so that maybe we certainly know with our ANOCA patients, we ask a lot about migraines. And sometimes that you'll start seeing a link when you start asking more about it, realizing that a lot of these women have suffered from migraines. You know, some of the work that I do is also looking at exercise, and you know, we know that exercise matters. This is from one of my very early papers, actually, from many years ago, showing that fitness, particularly for women, is different for women versus men, but certainly predictive of all-cause mortality and cardiovascular mortality. But at that time, there was actually no papers describing fitness in women. And additionally, the equation for what your fitness level should be for your age was based on these young, healthy men that were Army recruits in the US. And they said that was the equation for both men and women. It was in our guidelines. I never believed it, but then when I had my 6,000 women from the Women Take Heart project, I was able to show that the equation did not fit for these asymptomatic, healthy women. And we published this, the nomogram for fitness for women, and we validated it in another, both in a symptomatic population, showing that if you didn't achieve your age-predicted fitness level for a woman, you were more likely to die, but we shouldn't be using equations for men. And we also showed that the peak heart rate is not 220 minus your age for women using the same population. We came up with a less sexy equation, 206 minus 0.88 times your age, so nobody uses it. But nonetheless, accuracy of 220 minus your age, if you ever have time, go pull that paper where they describe this, and you'll realize it's the most ridiculous equation even for men. And the people who came up with it never thought it was going to be the most used equation by the lay public and by the medical community, because for most stress labs too, people use this as their equation to approximate if they've achieved their age-predicted heart rate response. But anyway, that aside, so recently we also looked at physical activity and mortality. And I know to this group this will be of interest. You know, we looked at a very large sample of the US population that answers annually their surveys on exercise. So this is over 400,000 Americans. They were self-reported physical activity. But nonetheless, what we found is that, you know, there were sex differences. So for men, they achieved the greatest benefit if they did 300 minutes a week of exercise, of physical activity, of aerobic activity, of moderate to vigorous extent. And if they did 300 minutes a week, they had an 18% reduction in all-cause mortality. Here's where the good news is. For women, women only had to do 140 minutes a week of the same level of activity to get the same benefit. And if women did do 300 minutes per week, they actually had a greater reduction in mortality. Their plateau was around 300 minutes a week. They didn't get additional benefit after that necessarily from a mortality standpoint. We also found the same with resistance training though. Men who reported doing 3 sessions per week, they got about a 14% reduction in all-cause mortality. Women only had to do about a single muscle training per week to get the same benefit, but if they did do more, they did get a greater benefit. If they did up to 3 times a week, they got the maximal benefit. So usually we're always telling women bad news, but here you could actually see that activity has a profound effect on women, and we should be prescribing it but maybe one day we'll prescribe it differently for women versus men. And this way we published in JACC in 2025 and just showed the different levels of both strength training. We looked at all-cause and cardiovascular mortality. When we use our risk scores, though, when you think about these sex differences, there's not a lot that comes out in them that's sex-specific, though, right? We put in the traditional risk scores. We used to use the ASCVD risk score. We're now using the Prevent risk score in the U.S. I'm not sure if you guys are using Prevent or not, because one of the limitations certainly is when you put in zip code, it's not going to be like it doesn't have our postal codes. And that's now representing race, rather than saying race is the social construct, and maybe where we live, it actually affects more of our health than saying based on your race necessarily. But that, nonetheless, you'll notice that whatever, even if you use the European score, right, it just put in male or female, but then you put in the traditional risk factors. And there are some sex-specific risk factors we should be considering. Things like pregnancy. I think pregnancy is nature's free stress test. It identifies the women that are at high risk for heart disease and high risk in the next 10 years. So if they have an event that happens during that pregnancy, there are the young myocardial infarctions, the young strokes, the young presentations of heart failure. And those adverse pregnancy outcomes, things like preeclampsia, gestational hypertension, gestational diabetes, preterm birth, having a small for gestational age baby, do put people at a higher risk for not just ischemic heart disease, but stroke and heart failure, specifically for the first three, where we do have a relationship with heart failure. So it's important for us to be asking that when we're asking about cardiovascular risk. These are highly prevalent. 80% of women bear at least one child, and adverse pregnancy outcomes occur in anywhere from 10 to 20% of pregnancies. So we should be asking a bit more about these, but I don't often see this when we're screening women. And we wrote this paper in the ACOG Presidential Task Force talking about the quote-unquote fourth trimester. The idea that after pregnancy, this is the time to identify other issues, but particularly some cardiovascular risk factors that maybe we wouldn't necessarily think about in a young person. Often those adverse pregnancy outcomes resolve, right? Like they might not be hypertensive just because they were hypertensive during pregnancy. They're often not diabetic just because they had gestational diabetes, but their future risk is high. This is the group we should be more proactive and preventive. The other things that can happen throughout a woman's lifespan that are sex-specific also need to be considered. Things like early menarche or late menarche, those can put people at a higher risk for cardiovascular disease. Infertility is a risk factor as well. Polyendocrine metabolic ovarian syndrome, the new term for PCOS, is, of course, we've all known for a long time that increases cardiovascular risk. Early menopause and premature ovarian insufficiency are things that have been identified as increasing or accelerating cardiovascular risk. History of endometriosis and uterine fibroids also. And so these are things that I ask every patient when they're coming in for preventive care, what do you have of these? But I will say that most patients, I don't see this documented by the family physician or the internist that might be seeing them. And we do need to think about it across the lifespan, right? Because we'll meet people at different stages. And so there may be things that are happening in young adults, and then there's things happening during pregnancy that we need to know about depending on where we meet them in their preventive journey, which hopefully we can do better in terms of taking care of our women. But part of the problem, as I've already pointed out, is that there's so many places where we have gaps in our knowledge. Well, now we've identified certain diseases that affect women, but because we weren't using them in studies until recently, we really don't know a lot. And I think that has been the hardest part of at least my journey in cardiovascular disease, because this paper was written, and please don't do the math, but I was a medical student when this was written. It even looks like an old-time journal now. But it was the New England Journal of Medicine and the way they published it. But Bernadine Healy was a female cardiologist, the first woman to head up the National Institute of Health, and a dear friend and mentor of mine. And she wrote this about the Yentl syndrome. So if you, any of you have watched either the movie or read the book of Yentl, Yentl wanted to study the Talmud, but she could not because she was a woman back in the 19th century. So she disguised herself as a man to be taken seriously. And so Dr. Healy used this as, particularly for related to medical research, but particularly cardiovascular research. Where were the women? Are we just assuming that they're going to present just like a man? Is that the only way that women are allowed to present? And she actually pushed to get research done. And because of her, we have the Women's Health Initiative, which I know some people may critique, but it was monumental that study happened and that money was given for that study. People were using a drug that had not been studied in women, and we really didn't know the safety or any of the effects, despite people saying it was the fountain of youth. We recently, this is a study from some other people, but they looked at trials that had been done that are registered on NIH.gov, and they said, well, where, are we including women? And they were from 2010 to 2017. And you can see the one striking thing, I know it might be hard to see, but where this stands out here, the disease type, that was pulmonary hypertension. So we do a good job of getting women into PH trials, but everything else, we do not get enough women into trials. It doesn't matter if we're talking about drugs, devices, lifestyle, procedures, or other type of studies, we under-enroll women. Lifestyle, we probably maybe enroll more women. Didn't matter where in the world the study was done. It didn't matter if it was a big or small study. It didn't really matter about age except for under 55. We were getting people under 55 into studies. Sponsor type really didn't matter. We really did a crappy job of getting women, but you see the lowest ones were when government funding was involved. So although government funding often makes a big thing about, at least in the NIH, we have to write, like, are we going to enroll women and people that are underrepresented? But you're not held accountable. So you can say whatever you want, but if you don't get them enrolled, you still got the money and you still completed the study. So that was 2010 to 2017. Don't get me started about pregnancy studies because we almost don't have any. We have a couple of randomized trials, CHAPS being one of the more recent trials that we have about blood pressure control, but we seem to not want to study pregnant women. Well, we published recently, we just presented this at ESC last year and had simultaneously published it. And so we actually updated from their 2010 to 17. We did 2017 to 2023. And we see that there is some improvement in enrollment of women. Women are about 40% of the enrollees, and we adjust based on prevalence of disease. You can see, again, pulmonary hypertension still doing a great job of getting women into trials, but obesity trials most recently have also been able to get women interested in enrolling in trials. Hypertension trials have also done a better job, diabetes as well. Still, heart failure actually improved their enrollment. They were the worst before. But I think our acute coronary syndrome, and particularly whenever we have devices or procedures involved, we don't enroll enough women. And we don't know if that's because women turn down, they don't want to take the risk, or how it's presented to them. Worldwide, I would say that the US has actually significantly improved their enrollment, and South America as well. And then in terms of age, again, we still are getting more women under the age of 55. We need to get older women into our trials too. And sponsor type, again, did better if it was at academic centers. So they tend to be the places that would get more women into trials. Again, government funding didn't necessarily help. And when I'm not trying to beat up on the NIH either, it's honestly any government funding, because you can register on NIH.gov even if it's not coming from the government. And why it matters is this, we learned in medical school, I learned here at University of Toronto, that when you have drugs, there's going to be a difference between men and women in terms of absorption, distribution, metabolism, and elimination of drugs, right? We learned that. And even in pregnancy, that there was a difference in pregnancy that we need to understand. But if we don't study them, then we won't know until these drugs are released to the public what is actually happening. And just think of some of our commonly used drugs. Diuretics, for example. We use these every day in hypertension, right? But the plasma concentration in women is higher than men by about 30 to 40%. So it's not surprising that there's electrolyte imbalance in women and more arrhythmia risk in women. Same with beta blockers. The plasma concentration is higher in women compared to men, and the heart rate response is often lower in women, and the blood pressure response. Maybe this is why women don't always tolerate the same doses as men. And I'm only pointing this out as, to think about the medications. And one of the first things I always do, since I only take care of women, is look, how many women were included in this trial? Does it apply? Do we know enough about it? And that's what we should be critiquing when we look, and we need to demand this inclusion in research, because women are 51% of the population. They are not a minority. They are not a small segment of disease that we are treating. And same with devices, technology, and as we're all getting excited about AI, we need to remember to not leave the women behind like we have done in the past, because this AI particularly, if you don't give them the women, they're not going to give out output that's going to apply to the people that you're caring for 51% of the time. We also need more money putting towards research, and I know Canada has made a big effort in the last few years, which I've been excited watching from across the way, seeing. But for the US, if I can just give an example, I have no clue what's going on in the NIH anymore, so this is a little old data prior to the current administration, because we can't figure out this administration. But breast cancer funding was getting about $2.7 billion. Cardiovascular disease was getting $2.8 billion. I already showed you the numbers of the deaths related to cardiovascular disease. And when we look at what amount of that money is even going specifically to women, it's only about 4.5%. So a very small amount. We need to really change this and, demand parity and inclusion of women in trials. And there is this important study that came out of the Rand School of Economics saying that when we funded women's health research, it actually saved lives. And they showed it for Alzheimer's disease as well as cardiovascular disease, that if we had invested, we would actually get a return on investment. So and I know everyone here, and I think Canada's making great movement. I see it. And they are funding trials specific to women, so this can change it. But we still have a lot of work to do, because like I told you, women are under-recognized, they're underdiagnosed, they're undertreated, and they're understudied. If the only thing we do today is treat women equally with our guideline-recommended therapies, I know we'll save lives. That's just the starting point, though. We need to study them more, and we need to study diseases that uniquely affect them, or even how pregnancy affects them, right? And what should we be doing earlier to save lives and not treat the disease state? Because I think ultimately we want to prevent disease. When we look for sex differences, though, we often find them. And I think the question of the future is, how do we harness, as we are all moving to electronic health records, as we're moving into this AI world, whether we like it or not, it's coming. How do we improve the care? How do we ensure that women are represented? And how do we remove the bias? Because again, garbage in will be garbage out. So we have to be part of those conversations, guiding people that are putting out AI. So those are really my conclusions. I will say that we need to make saving women's hearts a priority. I was really fortunate. The First Lady came to, when I was at Cedars, she came to hear about cardiovascular disease in women to learn more. And then she invited me to the White House shortly thereafter to really talk about it further, about what we had done in the time when she visited. We were very excited because she really put it as a priority, but now it's been pushed back to a back burner where we can't even put it into our grants when we're applying for funding, the word woman, because then we won't get funded. So, but I'll leave you with that, and I hope we can all work towards a better future. So thank you so much.
Thank you so much, Dr. Gulati. That was informative, thought-provoking. The discussion on the conditions that are more prevalent in women, understudied, poor outcomes are so important. Thank you for that. And I think we can safely answer your question in your title, that indeed there is a meaningful sex difference. And we need to do more research, obviously, around this. So I'd like to open this up to everyone, and also to those on the live stream. We have quite a few people listening in on the live stream. So if anybody has any questions or anything that stood out for them, if you wouldn't mind coming up to the microphone there, that would be wonderful. Thank you.
Thanks for a great talk, Dr. Gulati. That was fantastic. I'm just curious, just want to pick your brain a little on, like, what do we do next? So we know, and I know you're part of the Canadian Women's Heart Health Alliance. We're doing a ton of work. So maybe we just hone in on one specific example, like the chest pain protocol. You know, where are we with that? Does it work? Like, are we distributing it in ERs, and are they actually using it? Do we know this sort of thing? Like, even the guidelines that you led, are they working? Are people following them? Like, where does the data lie with that?
You know what's very strange about guidelines, which I learned after being involved in them, is that guidelines and writing the guidelines is a process. Implementing the guidelines takes up to 17 years for people to actually do what people have written. So it's a lot of education, a lot of things that, you know, we need to continue to educate. For the one that we wrote with the Canadian, it just, I believe, got accepted. And so I think that when that rolls out, and thank you for including me as part of that, but I think that once that rolls out, it'll take a while, because, and that's why I like how they were done actually here, because they didn't just involve cardiologists. We're not the front lines, right? If we don't get called, it's the emergency room, it's our family physicians, it's everyone. Everyone meets people at different stages with chest pain. So the guidelines that we've got to write here in Canada really involve people at the front lines, and hopefully can strategize how we go and how we increase the education. We did some surveys with them just to find out what people knew about even these differences related to women, and found that, not surprisingly, that there was a lot of lack of awareness. Some of the increased awareness was the people who decided to fill out the survey too, which always will happen. But I think that only way we'll know is in time and continuing to follow our numbers and following outcomes.
Thank you again for the lecture. It was really interesting. I suppose the question I had was about the bias a lot of women experience when trying to get care. And I just wanted to know, is there any information on if the gender of the primary care physician, or if the diversity of the care team matters to the outcome eventually, or do we just see across the board that there is bias regardless?
No, that's a great question, and I like this question. So yes, there is a difference, especially we have data from emergency rooms. So when a woman physician is involved in the care, the outcomes are actually better for women who are presenting with chest pain versus when a man is there. And when an emergency department has more women in that emergency room, then the man performs better than a man that is at a place with less women. So either they're talking, they're educating each other, or there's a greater awareness of the whole group. I think that to some degree that study that was published is a little biased, because in the emergency room, right, there's many people that end up caring for an individual. And so it's always hard to know, like, where along the line, did care happen, but at least that is, in line with many other pieces of data that are not specific to acute coronary syndrome, but things like we have data in the cardiology field for heart failure, where the female physician's much more likely to follow guidelines in both men and women, male and female patients, more so than a man who will follow them more frequently in their male patients than in their female patients. And I don't know if there's sometimes this bias that you worry somebody's going to have side effects to medications more in women versus men. If that's why we're holding back, even with statin therapy, something that I think we all use, I think that that's sometimes why people don't offer them, that there's an assumption they're not going to tolerate them. So I think we need to move past that so that we can actually adequately treat them. If they have side effects, then we move on and we'll find something else.
That makes sense. Thank you.
Any other questions? No? Well, thank you all for coming. Thank you all on the live stream as well. And Dr. Gulati is going to be here for the next hour to have a chat with any trainees. So please stay back, and we have more pizza left over. So.